Sorry for the delay. This is Tae Jung, and I'm start today's EPG conference. And this is the EPG today.
Okay, who will take it first? Oh, I forgot to bring the bottle of for the wine. Oyundari or Minjung? Who wants?
Y-axis deviation, and when we see the next two, there is a preceding P rate with before the QRS, but the QRS was at different size. P rate and QRS is maybe dissociated with possibility
Atrial tachycardia? Okay. Dr. Sop?
Maybe it's rhythmic dissociation. And I think some P is inside the QRS.
So, what is the Yeah, I fully agree with you, 100%.
Yeah, I'm not sure.
I think it's complex ECG. That's true.
Actually, I have no clue.
So, what do we have to differentiate based on this ECG? Okay, 5-second rule, copy.
So it's a narrow rhythm, generally regular with a few areas where there's some irregularity. Right axis deviation with a tall R in V1 and a deep S in V6. So there's right axis deviation and likely right ventricular hypertrophy. Alternatively, could also be like a dextrocardia kind of picture. For the rhythm, the P and QRS is dissociated, but the rates look about the same. Yes, the rates look about the same. So likely an isorhythmic dissociation. The rate is maybe about 130 or 140. So isorhythmic dissociation. Yes, that would be my diagnosis for the rhythm on the background of right ventricular hypertrophy or dextrocardia.
Can you mention about what is ECG criteria for the dextrocardia? Cytosine versus?
So for that one, there'll be deep S waves in the lateral leads, so 1 AVL, V5, V6, and then tall R waves in AVR and V1. That's what I remember.
Yeah, if you look at the limb lead, the lead one negative AVR, positive. So north-west axis, that's actually no man's land, right? If it is wide course complex, we need to suspect the BT, but definitely it is not BT. Anyway, the axis is completely right axis deviation, and the V1 positive, V6 even negative. So precordial leads shows some the reverse activation of ventricle activation. So, way to suspect some cardiac anomaly, and also I suspect this patient is Dr. Armstrong. Besides, okay, why should your time?
So it's narrow complex tachycardia in a patient with a reverse precordial transition. V1 is positive, V6 is deeply negative. So the QRS rate is the ventricular rate is high, around 140, and the P waves are dissociated from this. So if it is a pediatric patient, I would think of junction ectopic tachycardia because there's dissociation of A and B.
You mean jet,
Yes,
right?
yes.
Junction,
And,
yeah.
Or an 80.
Or 80.
Or 80.
So which
These-
finding they prefer the JT, jet? And
If it's a
which
pediatric patient, I will
Hmm?
more go with jet.
no, ECG based.
Based because there's AV dissociation, then jet becomes this. For 80, there should be still some 3:2 or some form of AV conduction, but I cannot see a pattern here. So more likely jet or with in a patient who has a right ventricular hypertrophy or severe right ventricular hypertrophy, like some obstructive lesion on the right side or left hypoplastic or dextrocardia.
Okay,
Yes.
let's look at the rhythm strip, lead 2. Sometimes QRS complex preceded P wave, sometimes P wave preceded QRS.
Mm.
So what should we do? What should we do for the analysis? Caliper, our personal weapon.
What precedes it?
I expected that.
Oh, you already
I-
measured. Oh, great. Okay, Dr. Zhang. Seong kindly measured all intervals. Red color is QRS, right?
Yeah, that's right.
And the blue is
P-wave.
P wave. PP interval looks
Regular.
regular,
By the way,
quite regular, right? QRS RR interval quite irregular. Did you measure that one by one by yourself? Wow. Thank you. I appreciate it.
I also think about this decision for a few days and I wondered about it.
Okay, great. Dr. Zhang? Sigh?
First of all,
Oh, no sigh.
first of all, I can find AV dissociation only two, and the axis is right, David, and as he already mentioned, based on the morphology of R wave, the amplitude R wave is much larger than V6. So I can assume that this patient has right ventricular hypertrophy, and in a perspective of the AT versus JT, I mean, if I see on lead 3, the QRS amplitude is quite different. So if it is 80, I think it would be very similar to each other, but I think it is different. So I think it is JT, and so maybe this patient is average, and the focus is so different, so the amplitude is so different, I guess. So this is the reason why this patient has AV dissociation, I guess. That's all.
Don't ask me. Give us your thoughts.
So JT.
AT?
JT.
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 Okay. Dr. Zhang mentioned a very important, pick up the very important point. If you look at the narrow QRS complex tachycardia carefully, QRS morphology change a little by little, especially when there is the irregularity to QRS morphology change. So even JT junctional rhythm shows the narrow QRS complex, very similar to the AV node conducted QRS rhythm, but if the focus is automaticity mechanism, it is a little different. QRS. Okay, so Dr. Oyundari, please finalize.
Short answer. Okay, also I can take a regular rates and right ossification, right ventricular hypertrophy, and AV dissociation. We can look at this close complex not constantly, and PP equals are constant. It means it could be the JT.
The JT.
Yeah.
Okay. So if it is jet, as Washi mentioned, usually the jet shows the regular tachycardia. But it is a little bit irregularity. It shows the irregularity. So somebody should discuss about that. Okay, Washi.
Since Seyong has nicely outlined the P waves, so this may be a normal sinus rate for a young patient because their sinus rates are faster, and the differing QRS morphology may be explained by fusion between sinus and the jet rhythm.
Sometimes a fusion,
Yes.
sometimes AV conduction.
Yes, I would.
I don't know how old is the patient, but 500 millisecond is pretty fast. Very young baby could be, but Dr. Om is here. How can we differentiate this atrial text? We meant the Washington meant the TP interval is pretty short. Is it sinus tachycardia or atrial tachycardia? How can we differentiate?
It is important to observe the pattern of the diurnal variation. Yeah, besides tachycardia, the heart rate is slowly going up. Warming up. However, it is tachycardia. Yeah, tachycardia heart rate is
Sudden onset of upset.
increase suddenly, 40 minutes, drop down suddenly.
Okay, Dr. Huang, welcome to join us.
Oh, thank you. Good afternoon or good morning, you guys. Can you hear me?
Yes, very clear.
Okay, good. So somebody discussed about the dextrocardia versus situs inversus. If this is situs inversus, your P wave should be abnormal. P of axis pretty much is normal. So probably this underlying the sinus rhythm or sinus tachycardia for baby is the normal heart rate, depending on age. Heart rate only about 110, 105. Okay. Second point is that clearly it is you have a more V than A. So this is ventricular tachycardia. Question is that your junctional tachycardia or common bundle tachycardia are coming from one of the bundle branch. But with the QRS complex, which is narrow, has to be common bundle or AV nodal region. So everybody talking about JT. Somebody mentioned about the irregularity of this tachycardia. So question is this irregularity coming in group or not? That would be another interesting observation. You see there's a regular and suddenly become irregular, more sort of but overall, if you look at the number, kind enough they wrote it, Dr. Zhang wrote all these numbers, pretty much irregular, except an exception of occasional regularity you see. And then P wave, none of them conducting. I don't think so. Because if you look at the 1, 2, 3, 4, 5, number 6 bit. Okay. The preceding number 5 has a short PR. Can you see that? Number 5 bit. Yeah, short PR. And the next one is the same or almost same morphology, narrowish looking QRS complex with P wave inside the QRS complex. Next one following number 7 does not even precede the P wave. So this thing is not conducting, okay? You see P over right behind it after the QRS complex. It's basically P wave marching through. So there's no conduction here. Now the question is, why is it irregular occasionally? That would be something that we have to figure out, right? Now, somebody mentioned this patient may have a left ventricle hypertrophy, right ventricle hypertrophy, right ventricle overload. In that scenario, what would be most likely the mechanism of tachycardia? Young person, baby. Probably the automatic tachycardia, okay? I am not certain this is JT. And the J4, JT, unless this is the medicated EKG, in other words, the patient receiving treatment, and the JT is not that slow. Baby is very fast. Goes about 200, 220. Sometimes in a slow size in JT is 189 in my career. And usually when JT, depending on where they're coming from, if JT coming from more compact node, you will see P wave right behind the QRS complex. Very sharp. But this patient does not have that. So I'm assuming this may be not compact node, but maybe common bundle tachycardia maybe. It's already tachycardia. That's what my guess is. But other than that, so patient does have right ventricular pathology, yes, certainly. I don't think a patient has a sinusitis inversus. And patient probably had a ventricular tachycardia with underlying sinus tachycardia, this completely dissociated. That's what I would read this ECG. Okay.
Oh, you mentioned about some pattern, and
Yes.
there's this area
Yes.
and this area.
Yes. That's the pattern, yeah. But the RR interval is not the same. It's varying a little bit, yeah. So question, the intermittent modulation by P wave, is it like ventricular phasic P wave kind of phenomenon? I cannot tell you.
Yeah, it's hard to say. Yeah.
Yes, right. So I think there's overlap P wave deforming a little bit of QRS complex, but actually I don't think it's a conducting.
Dr. Wang, even
Yes,
though it is the less likely, but in patient with severe COPD,
Oh, yeah, okay.
the clockwise rotation of precordial lead and right
Right.
exhibition. So how
But
did
the COPD patient would have typically, when that happens, complete right bundle branch block, not like this narrow complex. They're very unlikely. I have not seen COPD patients severe, corpulmonalis and that develop that kind of pattern without right bundle branch block. Often they also have anterior fascicular block together. So even more make a bizarre axis. But then this QRS is too narrow. This is gotta be coming from a very proximal bundle.
so? What is your?
I think this is a junctional tachycardia, the lower site than compact node.
Okay, so you also agree the JT.
Yeah, junctional tachycardia, but it's automatic tachycardia, most likely.
How
But I
how's the
don't know
PA?
why the rate is so slow. That's what bothers me.
How do you think about the P wave? And
P wave, I think, is still related to normolysis.
So you don't think it is the atrial tachycardia?
Oh no, it depends on age of a baby, but I think QRS P wave axis still within sinus range, and obviously child has to have a more vertical P wave, but then two is a positive, three is a slightly possible, so AVF kind of a positive. The AVR is like a biphasic, AVR is a negative, lead one is a biphasic. So you could guess it is a sinus tachycardia or ectopic tachycardia, but the children ectopic tachycardia also goes very fast, doesn't go this slow. Unless, as I said, the patient took medication, they're treating her with the pills. Maybe that's a different story. But based on this ECG, only thing I would say is the patient has probably sinus tachycardia. Now, in fact, that if a patient have a right ventricular hypertrophy, whether you have anticipated bigger P wave, children are mature. Okay. So I think that's what we can say.
Okay, Seong,
Okay.
could you give us more information about this patient?
Yeah, actually, this is a dish I found during preparing the last week presentation of the MS conference. Some of you might join to the conference. This is
Okay.
the first 3 years of male with dextro transposition of great artery, and
Okay.
he found the EGA at the birth. So he did the mustard LP at the 4 months, and he did the redo mustard LP at 2008. So the ECG was 1 hour after the redo mustard LP with cardiopulmonary bypass surgery, cardiopulmonary bypass.
Right.
So he was about 15 years old of the ECG, and he did the pacemaker insertion due to the complete AV block a few weeks ago. And so I presented this in the last week conference, so I will do it shortly in here. So this is the DTGA. So the RA goes to the RV, but it goes to the aorta, the systemic circulation, and RA goes to LV, and it goes to pulmonary artery. So we do the arterial switch procedure, and the mustard OP is one kind of the arterial switch procedure. So we make another route to the RA to the LV. So LV becomes the morphologic LV and functions as the RV. And the morphologic RV function as a systemic RV. So the RV flow goes to the aorta. And so he also showed the complete AV block. So we did the pacemaker implantation for this patient. So you can see that the SVC goes to RA to the LV. So this is the morphologic LV function as the RV. So we implanted the pacemaker, and you can see the morphologic LV goes to the pulmonary artery, and this is actually RV, and this is very second, and this function is the systemic LV. So let's go back to the ECG again. So he did the redo mustard LP due to the stenosis of the previous route. So he did the redo LP, and the CPB time was about 2 hours. And this is the baseline ECG he showed before the surgery. He has different axis of P wave before the surgery. And this is the ECG I showed. This is 1 hour after the operation. And actually, there was no ECG after this ECG. And 1 month later in the OPD, he shows this ECG. There shows AV conduction, but the PR interval is delayed. And about 10 years later, he shows a more advanced AV block in the OPD clinic. And recently, he showed the complete AV block, so we implanted the pacemaker. So I will go back to the ECG in here. Oh, sorry, this is not it. This is issue.
It's a long time ago,
Yeah,
right?
yeah, it is 15 years old.
Just
The patient was.
1 hour after operation.
Okay. So when at that time, how old was the patient?
15.
15 years old. And do you have a sinus rhythm ECG at the time?
This is the before surgery.
Before surgery.
And 1 month after the surgery, there was no ECG between these ECGs.
I would say that it was a kind of upper septal.
Okay, Dr. Ong, please interpret. It's quite confusing. So, right, the atrial side and ventricular side is switched, right? So sinus, the
Yes.
node exists in right atrium,
Yeah,
and the functional left ventricle is right side, morphologic RV, right?
yeah, that's right.
Yeah, please match the ECG finding and structure, please.
Yeah, atrium is almost normal. So, however, he underwent mustard operation. During the mustard operation, a lot of suture in both atria. So it's very easy to develop function or interatrial conduction delay. So, atrial rhythm is very common in these the patients like this.
So actually that is, you mean double tachycardia?
This tachycardia, junction tachycardia is also common just after cardiac surgery in pediatric patients.
So you implanted pacemaker?
Yes.
Where did you hook up the A lead and B lead?
Bachman, I implanted the Bachman atrial lead into the Bachman area, Bachman bundle area.
Can you go back that ECG that you showed before the surgery, before the heart block?
We
Before the heart block. You had a heart block EKG.
I implanted the
That's this one. No, just go back there.
functional.
Yeah, this one. Take a look.
Pulmonary system.
Yeah, this. Look at this rhythm here. Why the PR got longer and the PR was still exactly the same as what you see today, almost. Right? Look at the PR morphology. Smaller P wave, and it is pretty much a sinus rhythm behavior. Okay? Go back to that right after the surgery EKG that you showed to us. Yeah. What do you think? Do you think it's a different rhythm or same rhythm? It is the same rhythm. I can tell you why P wave looks like that. When I did the fellowship, we used to do muscle staining ablation patients. Now, if you go to the diagram in mustard. Yeah. So what are you doing here? You're basically excluding the left atrium. You see that? You put out this diaphragm patch. So left side come drain to the right side because you're making common chamber. And then through the ASD hole, they created this diaphragm baffle. SVC, IVC drain directly into the mitral valve. And your pulmonary vein venous drainage is very passive. So left atrium seldom have a really truly good contractile function when you do, muscle training procedure. So dominant or P wave you will see mostly from the right atrial sinus rhythm activity. That looks like that, like what we call half a P wave, what we used to call. So there is a significant dynamic change as a hemodynamic pressure, internal pressure, and then also the stretching, which is also responsible for the P wave generation, amplitude, and axis. So it's not uncommon you see what we call left atrial exclusion surgery, mustard or staining. You will see P wave relatively smaller than you anticipate. And then if you look carefully, that P wave you see very beginning is almost like an isoelectric activity, then positive. Go back to ECG first. That's why take a look at that. Lead 2, if you look carefully, there's a little hump in the front. Oh, so that's what we call half a P wave. Lead 2, yeah. You see, sometimes it looks like a negative, looks like a positive, sometimes it looks flat. Go to the third, next one, your POV gets smaller, and then get bigger again. This is all has to do with the volume fluctuation change. Second problem we see is that sinus node exit vary bit to bit when we do EP study in these people. So it actually muscle staining patients are very complex patients. It's very challenging cases, but also because we have to make a hole through their baffle sometime. But you don't see these cases anymore, I don't think. Only all the surgical techniques. So now it's much better. You don't have to put any diaphragm patch. Yeah, this is a case. That's why I thought that very unusual to have a right ventricular hypertrophy and such a small P wave. This is a very unusual thing to see.
I see the next ECG. The next one. Yeah, this ECG. Any fellow can interpret their AV node conduction status.
Well, for this one, it seems to have a wanky back kind of pattern. In the first half of the ECG, it's a bit difficult to appreciate, but after that pause, so from the mid, yes, look at that PR. There's a baseline first degree AV block, but then it prolongs as you go on, and then there's a drop. But a quicker way of identifying it is that after that pause, the first degree AV block, when you look at that PR interval, no, after the first pause, yes, that PR interval. When you compare it to the PR interval before the block, yes, the one before the block is longer than the one after the block.
Yeah, but EGM is notorious structural heart disease, which accompany the high degree AV block. So even though there is a progressive PR prolongation and the one bit drop, but still we need to exclude the potential high degree AV block. So I would like to recommend to measure the RR interval. Do you have the caliper?
Yeah.
So please measure the first. This RR interval is longer than this one.
Yeah, longer than the second RR interval.
Oh, then the copy was right. It's wanky bar AV block. But
Well,
if it is not longer, you should suspect other high degree AV block is associated.
in the for you guys to do just to look at the pacemaker indication, wanky bar is the Mobis 1 block, and often we say, Mobis 1 not generally does not need a pacemaker. No, this is not the case though. When you have a complete congenital heart surgery, complex one, you develop Mobis, this type of behavior with a baseline the already first degree block, you treat that as a complete heart block. Okay, for a pacemaker, don't wait. These patients, every single one get the heart block. Especially when you have a transpedition, your AV conducting axis already abnormal to start. And surgeon operate, put a bunch of stitch around the septum and the baffle, you're going to develop sooner or later heart block. Okay? You don't want to have a patient sudden death due to the heart block. So pacemaker indication is absolute in this patient. So there's a big difference between first bit of Wenckebach, long PR versus first bit of a Wenckebach, normal PR. Okay? The big difference. Second is that the patient QRS axis is a little bit abnormal. Number 3, patient has underlying prior structural heart disease surgery. So that's patient, every single one has a pacemaker. Okay? Yeah. Don't leave home without it. It's very important.
Actually, I forgot to mention that the attending doctor recommended pacemaker since this point, but the patient was hesitant about the pacemaker. So
Yes.
we read to the complete AV block.
Yes. But it is important to inform the patient the risk of sudden death and so on. Okay? If you look at the registry of pediatric surgery patients, sudden death risk, significant number of them die from bradyarrhythmia, not the tachyarrhythmia. About last time I remember from registry, about up to 38% is bradyarrhythmia. Okay? Because we miss the complete heart block business.
Dr. Does this patient need the anticoagulation? Maybe no.
No.
No,
Even after baffle surgery.
Aspirin.
no.
Just asking.
But they endocardalize pretty heavily, so you don't need anticoagulate most of the time.
And the last ECG, the P wave has changed. Now the intraleteral conduction delay has, now the P wave is broad and notched.
Yeah.
Patient aged.
Yeah. So after pacing, we did backman pacing, this became normal P wave duration.
I think it is very, very interesting ECG. It was valuable to come to the hospital even on the heavy rain. Thank you very much.
Dr. Quick question for you.
Yes.
Did you do any special technique that would advise our fellows to put a Bachman model pace in this patient? Because your bopple going to be on your way. Am I right?
I will show you the.
Yeah.
Oh, you prepared.
This is the last week conference. So I presented it here with Professor Rock. So I will quickly procedure. So we first
Okay.
did the angiography for the pathology outbreak,
Right.
and we put the LVB pacemaker, and we can see that the LVB area pacing. And we also did the Bachmann bundle pacing. Actually, the reason for the Bachmann bundle pacing is because there was no RA appendix for this patient. And one advantage of the Bachmann bundle pacing is it is safe area that could implant the aided very stably. So that's why we did the Bachmann bundle pacing. So this is the ECG after the implantation of the
But the patient did not have a baffle from the SVC to the mitral valve. This patient
Yes.
yeah, able to
from the SVC to the mitral valve. So my question is, how did you get into the backbone bundle from the SVC? In your figure, if you look at the muster, your SVC cannot access backbone bundle.
Yeah.
So how do we put that in? Do you go around the baffle?
This is baffle made by artificial, probably Dacron or
Oh, I see. So
Dacron.
you make a puncture, or what do you do?
This is baffle, and the other side is native tissue.
Oh, I see. So partial baffle, not a complete baffle.
This is a native tissue.
So you're talking modify the mustard procedure.
If we cut the surface like this,
Right. Because if you had the complete mustard, you have no connection. So that's why I'm asking that question. Okay, makes sense.
The angiogram.
Let's discuss this case next Wednesday conference.
Okay.
Thank you. It's already 8:10, so let's move to Jeff.
Good morning. I'm Pitachi Asamoah, and I'll be presenting today's EGM. So this is the case of a 74-year-old male who reported sudden onset palpitations that have been intermittently occurring for the last 2 years. It's at a frequency of about once a month, and each episode lasts about 3 to 4 hours, and occasionally associated with dizziness. Recently, during an episode, he had an admission to the emergency unit, and as part of his evaluation, his echocardiogram was normal. So this is the tachycardia that was documented. So we see that this is a regular tachycardia. The complexes are quite broad. When you check the carriage duration, however, it's just about 120. And it's difficult to appreciate the presence of the P waves, but looking at the ST segments, there are variations which could suggest some degree of dissociation, not necessarily a one-to-one AV relationship. This is his resting ECG after cessation of the tachycardia, and it essentially looks like a normal sinus ECG. However, looking at the marked area, I realize that there's a change in the QRS duration. So here the QRS is much narrower for the first 5 or so beats. Then it broadens slightly without any significant change in the PR interval. And then that's for another 5 or 6 beats. And then it becomes narrow again like the baseline. This is his chest X-ray, which is essentially unremarkable. So he came for an EP study, and this is the initial catheter placement for the study in LAO and RAO. His initial EGM parameters are as follows: cycle length 1046, AH interval of 95, HB interval of 50 milliseconds, and carriage duration of 80 milliseconds. And we can see that activation pattern is normal. On RV pacing, rapid ventricular pacing, the earliest A was in the HIS. So this suggests that the patient had a concentric atrial activation. Ventricular single and ventricular during ventricular pacing, VA block cycle length was observed at 320 milliseconds. And then on single study, decremental property was observed at 600, 380. So pre VAD was at 600, 400, and then after 600, 380, we see that there's incremental VA conduction. And then VA conduction ERP was observed at 600, 340, where we don't see any atrial conduction over here. So we move to straight RA pacing, and at RAP 700 milliseconds, and this was paced from the H1 to that's distal CS. This was the pattern. Then at RAP 600, we realized that there's a change in the QRS, so I'll go back. So here we see the QRS duration of 80 milliseconds. But then here we see that the QRS duration prolongs by about 20 milliseconds without any change in the HV interval. And then the AH interval increases from 65 at RAP 700 to 78, which is expected with the normal AV nodal function as we increase the pacing rate. So this is just to compare the EGM morphology or the QRS morphology and AV conduction at different RAP cycle lengths. So at 700, we have an AH of 65, QRS of 80, and HV of 50. At 600, there's broadening of the QRS, so now it's 108. AH conduction is slower than at 700, that is 78 milliseconds, and then HV is 50. At 500, the AH has prolonged further, 156, but then QRS is still 108, HV still unchanged. Then at AV block cycle length, which was RAP 420, as we see, AH interval is longer than what we've seen previously. This is 189 milliseconds. But the QRS is also broader than what we have seen previously. Now, the QRS duration is about 135, but there's still no change in the HV interval. So this is just to compare side by side the HV interval during sinus rhythm and during the RA pacing, and we can see that it's the same. There's no change in the HV interval. So far, what do we know? We know that this patient has concentric retrograde atrial conduction, and the QRS broadens during RA pacing, rapid atrial pacing with broadening, with what we thought was the delta wave, and there was no change in the HV interval. And there was also no change in the V activation sequence in sinus rhythm and during the RA pacing. So at this point, we identified that there is some ventricular pre-excitation, but we still had not figured out exactly where this pre-excitation is likely to be occurring. So we went on to multi-site A pacing. So we paced from the low RA, proximal CS, and then the distal CS. In all these locations, there was no augmentation, no further augmentation of the delta wave. It looked exactly as it had, it looked exactly the same with the same QRS duration. Then we paced at the HIS bundle, and we see that here there is some augmentation. So the QRS duration has increased to 144. Previously was 108 during the multi-site atrial pacing. And then during the straight A pacing, this is just showing the normal AV decremental property. So we can see the AH interval prolonging clearly, but the QRS remains the same. At AV node ERP, there was cessation of conduction to the ventricle, not even through what we believed was the accessory pathway. And this is the atrial ERP. So we give IV adenosine because when there's an accessory pathway, especially if it is antegradiently conducting, then when you block the AV node with adenosine, you would have preferential conduction, unopposed conduction through the accessory pathway. But here, after giving adenosine, everything stopped. There was absolutely no ventricular conduction at all. So we did an isopaterno study, and isopaterno increases AV nodal conduction. And so whereas initially we noticed the delta wave beginning from the RAP 600, after starting isopaterno, even at RAP 500, the QRS was still not pre-excited, was still at the baseline 84. But as we paced faster, this time at RAP 460, now we had the QRS broadening as we had experienced earlier. So on improving AV conduction, the onset of the pre-excitation delayed further. And then, so this is just showing the same pattern here at RAP 360. This was the block cycle length after isopaterno. Again, we see that this is where we have the maximal pre-excitation. So now what do we know? We've seen that there's ventricular pre-excitation on RA pacing. It's not augmented by multi-site atrial pacing, however, it's augmented by his pacing. There's AV decrementation, which is normal. And as it decrements, there is an increased degree of pre-excitation, which then remains fixed and then is maximal at the block cycle length. After giving adenosine, we lost the AP conduction completely. And after starting isopaterno, the pre-excitation occurred later than before isopaterno. So what this told us was that there's an accessory pathway that must be occurring within or after the AV node, but not directly connecting the atrium to the ventricle, which is why when we block the AV node, there is absolutely no antegrade conduction down the accessory pathway. But when there's AV node conduction, then we have manifestation of this pathway. So that gave us three options: would be a nodovascular, nodoventricular, or fasciculoventricular accessory pathway. And this is just to tabulate the differences between them. So for nodovascular and fasciculoventricular, there's decremental property, AV and then VA. Pre-excitation is minimal and fixed in fasciculoventricular, whereas it may change with atrial stimulation in nodovascular, nodoventricular. HV interval may change in nodovascular, nodoventricular, whereas it's fixed in fasciculoventricular. Here we saw that the HV interval remained 50 throughout. When there's adenosine, there's AV block. Multi-site atrial pacing does not affect the delta wave in both, as we observed. And then his bundle pacing in nodoventricular does not affect, does not pre-excite. Sorry, his bundle pacing does not pre-excite in nodovascular, nodoventricular, but it pre-excites in fasciculoventricular. However, the issue with this particular criterion is that there may be an assumption that the his bundle catheter is sitting directly on the his, but based on the individual anatomy, there's a possibility that the his bundle catheter may overlap the AV node. So there still may be some degree of AV nodal capture during his pacing, and that could pre-excite a nodoventricular or nodovascular pathway. So this is the induction of tachycardia. We had straight A pacing at 500. And then, so here we see that we have the normal concentric activation. Then this here is likely an APC that occurs because this is the pace signal is coming this way. Then this triggers tachycardia, and we realize that once the tachycardia triggers, we have an eccentric activation pattern, with the earliest A being in the CS1, 2, 3, 4 area. And whereas here we had a narrow complex at the baseline, at the onset of tachycardia, we developed a broad complex, a broad QRS. So this was the measurement for the tachycardia, cycle length of 330, AH interval of 67, HV of 48, and QRS duration of 140, which is consistent with the pre-excitation. So to summarize the data that we have so far, delta wave, which is manifest during RA pacing, unaffected by multi-site atrial pacing, but augmented by His pacing. Incremental property was observed, and there was no change in HV interval. V conduction terminated once AV nodal conduction was blocked, and the SVT was broad complex with the earliest A in the H12, and there was a mild increase in the degree of pre-excitation. So this is a diagram by Anderson et al. Just showing the pathway insertions. So this area is the atronodal transitional cells, and then here we have the compact AV node, which is where the decremental conduction occurs. And here we have the penetrating His bundle. So what I was saying earlier about the catheter positioning is that if you have a catheter lying this way and then you pace, there's a chance that it could still overlie the compact AV node and could pre-excite through the nodoventricular pathway. So with this, we made a diagnosis of an orthodromic AVRT conducting retrogradely through the left lateral accessory pathway, and the antegradely, because of the QRS prolong, the pre-excitation, and we thought the nodoventricular pathway antegrade conduction route. But from this, we thought that it's the left lateral pathway that was obligatory for the tachycardia. The tachycardia would have gone through the normal conduction anyway, but there was pre-excitation just because of the nodoventricular. So it was more like a bystander kind of accessory pathway. So we did a septal puncture and then mapped the position of the left lateral accessory pathway. And so pre-ablation, the patient was in tachycardia. So we paced at the tachycardia cycle length before starting the ablation, so that on termination of the tachycardia, there wouldn't be a sudden drop that could cause complications. And after onset of burn, within 2 seconds, we see that the eccentric retrograde conduction pattern terminates, and then it becomes concentric, which tells us that the left lateral accessory pathway was terminated. And so post-ablation RV pacing, well, even pre-ablation, it was still concentric activation. And this was the final EGM at the end. There's no picture of it here, but even after this, the RV pacing still showed that pre-excitation pattern as we saw earlier. So this was the final EGM. And in this final ECG, we see that the pre-excitation that we saw earlier in the starting ECG was not present over here. Thank you.
Why did you make nodoventricular as the this? Or more, it's more in favor of fascicular ventricular with a fixed pre-excitation.
Why did you diagnose nodoventricular?
Can you show me the table?
It's vascular. Yeah, typical vascular ventricular.
Which was a bystander.
Yeah, delta wave was not fixed. And we observed the augmentation of the delta wave during the pacing or after S2, the delta will be much more augmented. So it's against the basic electricity. However, we try to face the his bundle, the delta will widen. However, I think we couldn't capture the his bundle purely, just to capture the myocardium around the his bundle. So that's why the wide QRS after
HV remained fixed at 50.
Yes. Fixed HV interval is typical finding of classical ventricular. But at the early slide, you made me confused. There's some comparing the narrow QRS and wide QRS.
Yes.
Very early one.
Is it this one?
No. You measure the. Not this one. There's three, but I think this one.
Or was it a multi-site spacing?
That also favors fasciculoventricular.
You didn't measure the HV interval here?
No, the HV interval was
all along
here.
So anyway, HV interval was fixed.
HV
right?
interval was fixed.
Yeah. When I saw the previous slide earlier, you measured the HV interval changing, but the actual HV interval is same.
No, it's the AH that was changing.
Okay.
Just to show that there was the decrementation,
Mhm.
AV decrementation without the change in HV.
And I think it's the favor the vascular ventricular rather
as a
than
bypass.
However, we cannot explain the delta wave change in the morphology.
usually delta wave fixed
Yeah.
the vascular ventricular.
That was
So
the
we
issue.
can see the much more augmentation of delta wave during
Yes,
higher
with the
rates.
hip pacing
Yeah, higher-
was much broader.
No, high rates HRP or
Yeah.
S2.
So 700 at RAP 700, QRS was 80. RAP 600, it had
Little wider and then
108. And then when we got to the block cycle length,
wider,
was
much
even wider.
much more wider delta wave.
Yes. But for fasciculoventricular, we expected that it would be rather
Yeah.
fixed.
Then the measurements of HV are probably
In this case, HV is shortening.
not correct. Yeah. That's what that makes it. And second question on RV pacing, was the concealed left lateral pathway apparent? No.
No, not until the tachycardia induced.
So you mapped and ablated during tachycardia.
Yes.
So if it's a node
Okay.
ventricle, why you didn't ablate the node ventricle as well?
Node ventricular pathway is just bystander. Yeah, no tachycardia was induced at the left lateral axis pathway calculation.
Coffee.
Yes.
Can you go back to your slide, first one? I'm very confused. You make me more confused than anything I understood so far. So
Very intentional.
you have listen, Gavin, you are a 74-year-old guy. He got dizzy, and apparently he has been having tachycardia for last 2 years. Does that make sense to you? If a guy had the pathway, why the 74-year-old age having tachycardia? So he's age 72 by the time he had the first tachycardia. What made the difference? So clinical history doesn't make any sense to me. So what is the likelihood that if you have a pathway, have to wait 72 years of old age to develop tachycardia? Something has to happen. Can you explain that to me first, clinical sense-wise? That doesn't make any sense at all. Okay, so that's fine. Okay, then go to the next slide. So what do you see in this tachycardia? Where is the P wave, Coffee? If you look at the lead 2, right? After the QRS, right at the onset of S segment. Lead 2, yeah, that's a P wave. So your RP interval here is more than 80 millisecond. Agree? So they favor for the pathway, okay?
Yes.
All right. And then patient has what? Left bundle branch block pattern. Okay? So do you think this is pre-excited? First question I have for you.
It's difficult to tell whether
Doesn't
it's
look like a pre-excited to me because look at the V1, V2, V3. There's no really delta wave anywhere. How can you call delta wave? That's just only maybe 20 millisecond Q wave, R wave, or something like that. Especially V3. Take a look. None of the 12 leader pre-quarter had the pre-excitation here. Looks wide to me. Okay? Okay, go next slide. So do the fine, and then this baseline, okay. So patient has a first degree almost AV block, but not quite there yet. X is about the same, except a little different V4, V5. Okay, keep going. Now the one more thing I forgot to ask you. Go back to EKG again. Lead 2. Take a look at what do you have at end of it? Small notching, QRS complex notching. So the patient does have what? Interventional conduction delay. Agree? Lead 2.
yes.
Terminal
Yeah.
RSR. Okay? Okay. Let's go. Next. But chest X is fine. Look good. Keep going. Okay. Now, where you pacing? Now go back there. Where you pacing? IV catheter. What do you
So
see?
this is baseline sinus rhythm, and this is
Yeah, no, I know, but what do you see in the baseline? I'm asking you, RV. What is that sharp spike? RV1, 2.
Yeah.
That's a right bundle? Is it not a right bundle potential? How can you pace if you're thinking patient have a node ventricular, node fascicular right bundle? Did that help you? This actually pursue away from you diagnosis. I would suggest you go take a look at that. I bet that's a right bundle. Your catheter position is also looks like a right bundle. Go to fluoro, take a look. Look at the way this thing is. High septum, right across the his bundle, just below. That's a typical right bundle. Distal, you're pacing. Okay? All right. Next. So what do you see here? Baseline. Okay? Agree? His bundle is earlier first, right? Subtle. But a little bit about kind of a more than usual concentric pattern is a little bit unusual because you have B7A56 is earlier. Okay, keep going. Okay, keep going. All right, keep going. All right, go back there 1 second. I just forgot. Yeah, it's extra stimulus. You just show the one slide. Keep going. Forward. Forward. No, that is A pacing. B pacing. I want to show you something in the V. Yeah, they're right here. So if you look at your CSC electrogram, okay, what do you see? Do you think a CSC EGM from 400 milliseconds to 380 is the same or different? I want you to pay attention to the His bundle 3-4. His bundle 3-4, A is what? Negative? Flat? His 3-4, yeah, 400 milliseconds. Go up there. And then 380 millisecond, what? That's a negative. Flat, whatever. And then that became positive. Similarly, your HR EGM changed. And then also your CS EGM changed. So you pay attention to that, okay? You had a 1 point. There's also, if you go back one slide, I think you're pacing, ventricular pacing faster somewhere. I just can't remember now, before you block, I think. And you can see that the CS, his activation time change, okay? That is already suggests that there might be pathway hanging out in the CS. If this was all the way concentric his bundle activation, there's no reason to change HR activation, his bundle activation, whole 9 yards. So I keep telling you guys, watch his EGM, okay? All right, keep going. Go forward. I just trying to make a comment for you. Keep going. Okay, so HRA pacing. Look at pay attention to the his bundle activation, right? Beautiful, 3-4. 2, 3, 1, 2, right? That's appropriate. All right, keep going. Same, keep going. It's all same, right? Look at your 500 millisecond pacing. AH is longer, but his activation is the same. And your QRS is wider. That's your argument, right? You think this is where the pre-excitation is. If this is a pre-excitation, like Washim said, it's got to be fascicular ventricular below the his bundle because his activation is the same. How can you have a node ventricular pathway, your his bundle EGM doesn't change? Because then next question is where's your pre-excitation ventricular pathway inserting? That would be the question. So then your HV should change regardless. Doesn't change. So it's very hard to argue here this is node ventricular axillary pathway. Because if a node ventricular pathway, somewhere ventricular septum got activated earlier, that I'm assuming that's where his bundle is. But HV is the same, and how can we argue that this is node ventricular? Maybe your HV should be shorter because the septum get activated earlier, right? But it's not convincing here. Your measurement is 50, 50, 50. So I said, wow, that doesn't make any sense to me. So think about that, okay? Next. So you rapid the right atrial pacing. So what you see here is basically Wenkiba. You agree?
Yes, with
Okay. So what's the HB now? Same.
HB was still 50, yes, but the
Yes.
QRS was
How can you argue even though the Wenkiba cycle, if a node ventricular pathway, yeah, assuming that if it's a Wenkiba happening, if it is a node ventricular pathway, AV node plus axillary pathway. Am I correct?
Yeah.
Right? So then what would happen? Your blocked beat compared to the non-blocked beat, your HV should change. Because your pathway is going to conduct one, the other is not going to conduct. Make sense? Because the AV is going to prolong no matter what. But then if your nodal ventricular activation also has to be Wenkiba. How can you have a nodal ventricular axillary pathway Wenkibaking without Wenkibaking? That would be something that bothers me quite a bit. Okay? So think about that. By the way, nodal ventricular axillary pathway does not Wenkiba. Everything or nothing. Blocks doesn't conduct either way. Okay? That's something that's very unusual. I've never seen a nodal ventricular axillary pathway Wenkiba. Not yet. Maybe there is, but I haven't seen one. Okay, next slide. Keep going. So it's fine. HV is still same. Okay, keep going. So I'm not sure what you're arguing here is pre-excitation or this is aberrancy. Okay, so you keep going there. Go to the back up to your slide now. What I need you to do now, right here. What I need you to do, I want you to measure, okay, from his to the distal CS LV, which that get longer when your QRS get wider. What I'm trying to say is this is a left ventricular left bundle aberrancy. In that case, your lateral wall will be later. Make sense? So go back. This is your homework for you, okay? I want you to measure that. Tell me what you think it is. All right? The way that you degree of proportional pre-excitation, you think whether his to the lateral CS VLV getting longer or not. Because this is a nodal ventricular, there's no reason to change. But if this is an aberrancy, yes, she's get longer. Okay? So you look at the EGM carefully when you guys do that, please. Okay, keep going. Keep going. So multi-site pacing is fine. You're trying to prove that there is, same cycle length, the same pre-excitation index here. So if this was nodal ventricular, would make sense. But then pre-excitation index doesn't matter where you pace, doesn't change. But again, you need to measure from the stim to the distal CS, so what change. Okay? Or his bundle to the distal CS. Okay, keep going. Well, his spacing is fine. It's good. Okay, that's we understood. Keep going. Maybe you know the decremental property here. So you measure that basically decremental conduction and the pre-excitation index. Here looks like did not change it too much. Agree? Same to me, 500 versus 460.
Yes.
Think there's a change?
No, the change is 700 was narrower, but 500 and
Right.
460.
500, 460 is about the same,
Yes.
right? Yeah. Okay, keep going. And then that's okay, that's good, all good, keep going. Keep going. Okay, keep going. Here, I got a problem here for you. When you present the next time, don't bring any trace thing, no capture, okay, please. 500 millisecond. You could hardly argue this is an effective pacing. In other words, for us to prove that this is an effective pacing, you need to show every single bit capture. Okay? Especially when you present the international conference, don't ever show these steps. Make sure you have a consistent capture. Okay? That's what we are pacing for, not in science. Okay, I just want to point that out. Keep going. Okay, here. Now we got a issue here. So you say 460, 360, okay? You have a maximum pre-excitation, 460. I mean 360, I assume. That's what I'm trying to argue. Am I right?
Yes.
Okay. So then I want you to tell me why the QRS complex changed. And then lead two, I assume that's what you're showing second. Do you see the QRS complex of 3 top surface ECG?
This one.
460, yes, is an upright. 360, now you're biphasic. Delta wave actually changed? You know what it is? How are we arguing this? If you have a pre-excitation, pathway to pre-excited, you should see consistent QRS morphology widening, not changing QRS morphology. That is against the pre-excitation, unless patient developed a concomitant bundle branch block or something like that. But even then, I think it's very unusual. So I think you need to think about that, what I'm telling you. Okay? Okay. Because when I look at in my eyeballing, I could be wrong. But if you look at the CS EGM, okay? 3, 4. 1, 2, 3, 4. Ventricular EGM, LV EGM, left ventricle, V, CS. This, yeah. Look at the CS now. It's 360, 3, 4 again. Completely different.
Yeah.
So this favor for what?
Aberrant.
Aberrancy. Okay? It's not a fixed citation because your CS LV 3, 4 became later than QRS and 460 came on time with the CS. Even eyeballing, I can tell. So left ventricle conduction got delayed because it developed a left bundle branch block. That is my argument for you. Okay? So think about that, please. So next time, before you say that this is not a ventricular, all that is important. But I think you do measure intracardiac measurement, changes should be appropriate according to what you're thinking. Got it?
Yes.
Okay, good. That's all I have to say. I think you're basically ablating left side of the pathway, concealed mostly. And then I think what you see in different degree of aberrance you see by pacing rate. Sometimes you can have a sinus rate. Your first ECG, your sinus rhythm occasionally got wider and slightly wider and narrow. That really doesn't bother me. I would not buy that as a pre-excitation. Would make sense if your heart rate suddenly increased pre-excited. Yes, that would make more sense. Not in the same rate. Okay?
Yeah.
Okay. That's what I have to tell you.
Thank you.
I appreciate the precise and very clear lesson. If I summarize, number one, we need to look for the His bundle electron very carefully. If there's a His bundle polarity and interval is same, whatever the ECG shows the pre-excitation or the aberration, it happens
lower than the AB node. That's one lesson. And the other one is I learned it the first time. It's a very useful technique to differentiate the aberration from pre-excitation. If you measure the CS local far field V interval, if it is left bundle branch block pattern or aberration, it is prone. Yeah, it's a very useful technique, and I appreciate it. So Dr. Huang,
Sir.
yeah, do you think that this patient doesn't have a vascular ventricle or any other different bypass tract, or just the progressive aberration?
I think is probably just progressive aberrancy because the overall axis is remaining pretty much the same, except the second lead that is become biphasic. And also fact is that the patient, baseline ECG, when you have a normal sinus rate is the same, and then suddenly they develop, take a look at it. I think it looks same rate to me when he showed me. I was very interested looking at that. Yeah, right here. Sinus rate doesn't change yet, gradual progressive increase about, QRS. If you look at the very first, bit, you would lose a 1, 2, 3, 4, 5 bit, fifth bit, you lose a small Q. You see that? There's no Q there. Okay? There's a Q. No Q, get wider, and then what happened? Well, come back again. So it is something that really bizarre bothers me. Second thing, what did I point out lead to? RSR, remember? Terminal, there's a small R. No, yeah, you can see very first 2 or 3. First 3 bit has a small tiny R, yeah. When you have an aberrancy, that guy disappear. Okay? I think this is just interventricular conduction aberrancy. That's what I think. Okay?
Did you see the small tiny QA?
What?
Yeah, there
Well,
is.
there is. I'm not imagining, okay? So it is important to see these stuff, okay? Look at that gradually disappear. Next one is there. Third one, because smaller one, tiny one. Next one, no. Third, the first wide bit,
I
bit.
agree.
At very end, keep coming. End of QRS, there's a small notch, yeah, and then next one disappear. Okay, so there's a
Your
flow.
eyes never get aging.
Well, keep looking. You have a good imagination, you can see it. Okay.
Yeah,
All right.
agree.
Good lesson for you guys.
Okay, another question from fellows? That is also interesting, educationally important case. And even though it may not be the vascular ventricular, don't imagine to try to ablate the vascular ventricular. Okay, you will make.
No, but I think it's encouraging that the people trying to make a difference or think a different thing out of box. That's the important concept. Okay, Kofi? This is not meant to just moralize. No, you need to start continue to think the same way. Is there something else here? Okay, otherwise all this is boring. It's educational. This is a good thing. Good for us. Okay, good job. All right, gentlemen. Thank you so much. I'll see you next week.
Thank you very much. And stay